The CCG uses a scorecard to rate interventions according to the strength and quality of evidence. Is the evidence base robust? How confident are we the evidence reflects the true figure? The magnitude of health improvement benefit, so to what extent the intervention improves the health gain for the patient over a comparator. Prevention of future illness. Supporting people with existing health problems, so does the intervention improve the quality of life for the patient? Cost effectiveness. Does the intervention address any health inequality or inequity? And does the intervention deliver national or local targets? Once the interventions are scored against these criteria, the total score for each is tallied. Those scoring above the commissioning threshold may potentially be commissioned, and those below may potentially be decommissioned to release funds for investment elsewhere. For each scorecard, we are searching for evidence according to a very specific question, a PICO question. Here, P is population, I is intervention, C is comparator, and O is outcome. And this sets the parameters of our search strategy. The question to be answered is the evidence base robust? Here we are assessing the reliability of the evidence. How confident are we that the evidence reflects the true effect that can be obtained using the intervention or service in question? We consider the type of evidence. For example, is it just based on case reports or on a randomised controlled trial? We also look at whether there are a number of different studies giving the same or similar results. Systematic reviews and meta-analyses, where a range of studies addressing the same question are identified, appraised and synthesised, are useful here, as are Cochrane reviews, which are considered to be the gold standard in systematic reviews. We look at how good the studies are, looking at how large the study population is, whether there's been a suitable control group, any systematic biases in the way the study was conducted, how likely the same result could have been obtained by chance, or if there was something else that could explain the results. We also look at how well the available evidence addresses the PICO question that's been set for the intervention. How similar is the population, the comparator or the outcome? And how well is that answering the question that the CCG wants to answer? The question to be answered here is, to what extent does the intervention improve the health gain for the patient over a comparator? This question is only concerned with health-related improvement. Physical health and mental health are included, but to be consistent with the CCG's commissioning policies, such as individual funding request policy, social factors will not be considered. Negative impacts must be taken into account if the evidence showed that this intervention reduces health benefit in any way. The main thing to note here on the PICO question is the importance of setting the right comparator. For example, the health benefit of comparing open surgery with keyhole surgery could be negligible, whereas comparing open surgery with conservative treatment or watch and wait, it could produce a much higher benefit. Again, the scores here range from 3 to 40 points. The question to be answered is, does this intervention support primary or secondary prevention of future health conditions? Primary prevention is any health and well-being intervention that might prevent the onset of a disease in the future in an asymptomatic population, whereas secondary prevention are measures that are taken to manage risk for a medical condition that's already known, or identify a condition that's not yet symptomatic and may be improved, so things like cholesterol-lowering medication or cancer screening. This question relates to the extent the intervention prevents future illnesses, and it relates to the prevention of other illnesses, not progression of the disease that the intervention is in place for. Where possible, we're trying to score interventions against the comparator. The question to be answered is, does this intervention improve the quality of life for the patient with the condition in question? This relates to an improved quality of life that would not have been possible without the intervention. It takes into account an assessment of the baseline health state or health utility prior to the intervention, and considers this against the improvement in quality of life that can be achieved following the intervention. Health utility is measured on a scale of 0 to 1, where 0 is death and 1 is perfect health. So a very low health utility would be for a condition that has a very large impact on health or quality of life. High health utility is one that has a lower impact on quality of life. We're also taking into account the effect that the intervention itself can have. So, for example, a very serious life-threatening condition would have a very low health utility. But say if the intervention in question was to send out a leaflet, the impact that that would have on the health gain would be minimal compared to perhaps some surgical interventions. So we're looking at both the condition and then how much it could be improved by the intervention in this score. The question to be answered is, what is the cost effectiveness of this intervention? Here we're looking for health economic studies that have been conducted in a comparable NHS setting so that we can assess the cost against the benefit of the information. If there's no information available, this will default to a score of 10. The question to be answered here is, does this service reduce or narrow identified inequalities or inequities in the local population? Health inequalities are unjust differences in people's health across the population and between specific population groups. Health inequalities are unavoidable and are socially determined. We use data and intelligence to highlight where certain groups are disadvantaged in terms of their ability to live longer, healthier lives. These can be caused by, but not limited to, socio-economic differences, age, ethnicity, educational attainment, and employment factors. Here we are considering if there are any inequalities associated with the underlying disease or condition and in the implementation of the intervention, and these can be direct or indirect associations. For example, the evidence tells us that those in low socioeconomic groups are more likely to smoke, and smoking is associated with respiratory illnesses, amongst other things. Therefore, there's an indirect association between low socioeconomic status and respiratory illnesses. A direct association would be where a particular illness or disease is only found in a particular population or is a result of being in a specific population. You're more likely to need the intervention in question. For example, those suffering from asbestosis are more likely to have come from a lower socioeconomic groups or working in manual labour. Here the question is, does this intervention support the CCG in delivering identified national and local requirements or targets?